Good afternoon, everybody. Like I say, I'm Julianne and I'm the matron on Frozard ward. One of the questions I set to some recent Band 6s was, what initiatives would you like to take forward and how would you like to implement that, and any barriers? One of my staff, so I take no credit for this presentation, this was one of my staff took it forward, and she wanted to do about sepsis for children, because it's a really big bundle out there for adults, but we hadn't really implemented anything for children, and so that's what we're going to do. So just so everybody knows, sepsis is known as a blood poisoning, and it's a reaction to an infection where the body attacks its own organs. It can occur from an infection, potentially life-threatening. Around 44,000 people die a year from sepsis, and 1,000 of those being paediatrics in the UK, which is quite shocking, really. So what causes the symptoms? So your normal way, our body fights infection, it keeps infection localised to one place. White cells travel to the site to destroy the germs, and processes occur within the body such as tissue swelling, which helps infection spreading and helps to fight, which is known as inflammation. So I know this is basic for a lot of people, but just so we know. So if your body is weak or you have an infection that's quite severe, the infection quickly spreads through to the blood. The immune system goes into overdrive, the inflammation affects the whole body, and then you get a widespread infection, causing tissue damage and interferes with blood flow. So some of the tools that one of the staff looked at to bring it in with here, there's the UK Sepsis Trust. SORT is our Southampton Oxford retrieval team. That's the paediatric retrieval team that would come to any child that we needed to have taken off island if they were critically ill. Obviously we've got NICE guidelines, we've got the NICE risk stratification tools, and we've got our own localised paediatric guideline book on the ward. So these were all tools and guidance that Gemma looked into. These are the main signs of sepsis, for what everybody says thinks sepsis. So again, it's an increased respiratory rate, an increased heart rate, cold and having rigors, shivery or looking flustered, very low or very high temperatures, that's where people can get confused, pale, mottled or reduced capillary refill, cyanotic, rashes that don't go away, and sickness and diarrhoea. But as you can see, that could be for an awful lot of things as well, clinically wise. A really weak, high-pitched cry, reduced urine output, aching muscles and tiredness, not being able to take anything orally, drinking-wise, drowsiness, altered mental state, and a source of infection. But again, these aren't exhaustive, and they're also symptoms of lots of other things, and certainly in childhood illnesses. So how can we try and prevent it? From our own judgment, have we seen things like this before? In paediatrics, I think in adults you use the NEWS charts. In paediatrics we use PEWS charts, which stands for Paediatric Early Warning Score. We've got a sepsis screening and action tools, and we've got the Sepsis 6. So these are the tools that we've been devised. Everywhere should have these from the UK Sepsis Trust. So this is your paediatric sepsis. The next one is our PEWS tool, and there's your sepsis system, what to think of, like an aid memoir. So we brought it in, like I say, there was nothing on the island around sepsis at all. We got, well, it was for paediatrics, there was for the adult side. So Gemma did a lot of work with our paediatricians looking at it. So paediatric sepsis is one bundle of care designed to facilitate, promote recognition of sepsis and deliver 6 elements of key care. And it's designed to give life-saving care within an hour if sepsis is suspected. Just going on to how did it arrive here, sepsis is a bedside tool, and as you can see it's been out in the UK since 2005. It was drawn from international guidelines developed about surviving sepsis, and we set about it, this is from the UK Sepsis UK Trust in 2011, and for us, sepsis, does it work? Because it's picking out the 6 memorable signs. Those are the 6 signs that you give 6 elements of care within the hour. Give them high flow oxygen, obtain intravenous or intraosseous access and take bloods, give IV antibiotics within, and again this is all in the first hour, and there's protocols for which IV antibiotics we use. Consider fluid resuscitation, and getting somebody seeing your clinicians early on. Now, obviously from Guernsey, we've got a paediatric consultant on every shift, every hour, but sometimes they're on call and sometimes they're not on site. So it's about getting that senior clinical opinion if you're at all worried, and consider inotrope support early. So it's always about thinking we have to reduce the threshold for sepsis. And do they have any reduced thresholds? So the kind of things we're looking at for are any of our children immunosuppressed or compromised? Have they had recent surgery? Any child with long-term conditions? High index of clinical suspicion, so it's always think sepsis. And have they got any indwelling catheters, devices or lines already in? And that could be for a number of our children. So to stop sepsis, it does save lives. And this is the kind of tool that we use. So we've got different age groups. We have our Sepsis 6 pathway, and it's based on the UK Sepsis Trust. So we've not made anything different. We've made it as easy for everybody to follow from wherever they would work. We do 3 different ones: under 5s, and then 5 to 11, and then over 12s. And we also have a sepsis box, which I think are out on every ward now, with everything there ready to get all this started straight away. So again, who's responsible? We all are, and we all have to ask, could it be sepsis? Again, we get a lot of our health and safety and our human factors and things about from the airways. So British Airways have even introduced it into their aviation training, and so it's all about who we can do. So I thought I'd show you these around.
Good afternoon, everyone. Slightly different talk, although very interesting, because I actually had one of my patients ended up on Fossard a few years ago with septicemia because of a dental thing. So actually we are all interrelated. Right, well, thank you very much, Vicky. Probably this is a bit different for everyone, but clinical techniques that we use for filling primary teeth. First question is, why do we restore primary teeth, baby teeth? And a lot of people sadly still have the attitude, well, is it necessary? Well, if you have mouths presenting like that, there's definitely a reason that we need to treat these teeth, okay? Cause all sorts of problems. It can affect development, education, sleeping. If they can't sleep and they can't eat, they're not going to learn at school. Family life, parents feel guilty, parents can't sleep, can't get to work, and self-esteem. And if you lose baby teeth early, you can then get problems with the position on the grown-up teeth. So all these things are really, really important to try and maintain complete arches, especially somewhere on Guernsey where most orthodontics is in the primary care setting and is very costly. And so that also introduces differences between socioeconomic groups, because those that can afford, those can't. You get to adulthood, and go for a job, it's all there, there's all the evidence. If you can smile at a job interview, you're more likely to get a position than if you turn up with your hand against your mouth. So it is all very, very relevant. And this is just one study with a few figures. It looked at 110 children and 110 carers. The children were aged between 4 and 9. Now when you get 1 in 5 feeding back that they're having problems playing, or 1 in 4 feeding back that they don't want to smile, these are really significant figures. I won't go through all of them, but 1 in 5 speaking. And then from the parents' point of view, nearly 40% the child was irritable. What's that going to do to the parents? What's that going to do to the home life? Feeling guilty. I get parents crying in my surgery nearly weekly. That's 1 in 2. So, we need to look at dental decay, and we need to look at a treatment that's going to work. So I came out here in 2011, and there are a lot of fillings in teeth, and there are a lot of decayed teeth, and there are a lot of teeth that had fillings which had more decay around them. So I decided that actually I wanted to look at, how can we do things better or differently to see if we can improve the outcomes for our patients. So this is rather a retrospective Safe for Every Day, because we've actually done the work, or are doing the work. So what restorative materials were being used? What was being done locally? Conventional fillings. Right, so these are some examples. Here you'll see actually these white blobs are, and here, these are faulty fillings. These are where they've been put in without using good techniques, which is often really difficult in children. So you've got swollen gums. You've got a couple of silver fillings there, which actually are really quite good, but the white fillings there are not adequate. Sadly though, you can get silver fillings that then break down, and you can see where that one's broken down. So secondary decay, more of a problem, more likely to lose a tooth. Or in this case, decent filling, but sadly part of it's broken off because the angles are slightly wrong. So fillings that have been done but perhaps aren't very good. So the alternatives: stainless steel crowns. There's an example of one, and there's an example of three, which actually were ones I did last week. Well, two of them I did last week, one I did the week before. So, you know, they're not that difficult. I'm not that clever. Advantages and disadvantages. And yeah, everything has advantages, everything has disadvantages. So for conventional fillings, if you've got fillings like the ones I've shown you, there's two silver ones in the second two pictures, they need local anaesthetic. Waving a needle at a 3-year-old, 4-year-old is not actually terribly pleasant for the child or for the dentist. Compliance. It's all very well putting the local anaesthetic in, you've then got to sit still while you use a drill whizzing round, and you need quite long appointments with mum sitting in the corner going at every moment. You have to take the tooth away, you can easily damage the adjacent tooth if they move, you know, you've got a burr going around very fast. However, it's easy in adjacent teeth because you can just whack through both of them. Nowadays you can get good aesthetics because sadly they're virtually banning us from using amalgam, but that's another story. Preform crowns, okay, how do they work? Much less technique sensitive. In the preform crowns is a very old technique which was never really in favour. In the 1990s there was a dentist in Scotland, Norna Hall. She had a huge geographical area which she had to cover, and the only way she could control the children's teeth was to whack these crowns on the teeth. She wasn't taking the decay away, she was just literally sizing them up. They come in 6 sizes, putting them on, cementing them in and walking away. She actually got hauled up in front of the paying body because why was she doing all these crowns, and in front of the GDC I believe. And then they discovered they were working. And so this absolutely brought a huge new concept onto crowning primary teeth. Okay, because prior to that the crowns had all had very careful caries removal. So it became known as the Hall technique. Now, we don't always do the Hall technique in the department, we do it when it's appropriate. But if you're using a Hall technique, you don't need local anaesthetic. If we're taking decay away, then generally we do. You need less compliance because you can do shorter appointments once you've sized up the crown. You won't damage adjacent teeth. Sometimes you need a second appointment because you have to move the teeth apart slightly. They are very challenging if we try and do 2 teeth together. And the aesthetics. This is always the bone of contention. The children tend to love them. They call them their princess crowns, dinosaur teeth. You know, we can get around them that way. Bionic teeth, superhero teeth. Parents don't like it so much. Partly, I think there's a guilt element that it's, you know, if my child's seen with this silver tooth, it's because I've failed. And the important thing is to get the parents looking positively to the future. Again, that was a little chat from last week, and this one is as far forward as you're going to get him, and I really had him sort of putting his lips up for me. So they have pros and cons, both of them. Right, so, you know, where's the evidence? I'm telling you I think they're great, but is there evidence? The amazing thing is that all the evidence I've picked this time is all out of one journal. So I've been really lucky, and it's an international journal, and it's this year's. So we started this in 2011, but the evidence is still coming out. Systematic review, they looked at 31 studies, they looked at 12,000 restorations, and after a year, 1 in 8 will have failed if over at board using fillings, crowns, and white fillings, silver fillings. But for the crowns, the success rate was 96%. So you're looking at 4 failing in every 100. Another study, and this was just looking at the Hall technique, and this was putting an ordinary filling in one side of the mouth and a crown in the other side, and a Hall technique to crown, follow up after 25 months, and the failure rate for the ordinary fillings was 32%, so that's 1 in 3. And again, the failure rate for the crowns was 6%, so that's 6 in 100, so much better odds. And finally, these aren't figures, but this is just a part of a conclusion. Again, another study, I have got all the references if you want it, 15-year follow-up, so huge follow-up, confirming that the crowns have a longer survivor time, lower failure rate, better short and long term compared to other materials used in primary teeth. It reduces future visits, improves patient outcomes, and increases cost effectiveness. So there's the evidence that supports what we've been trying to introduce in our service. So having decided we're going to change, having made the decision before we could start, we had to train the staff, because although I was familiar with them, the rest of my team weren't, so that came with a bit of a gulp. We also produced a leaflet for our patients and parents so that they knew what we were up to. So the next stage was actually to do, which we did, and now we're sort of at the stage of reflecting and are they working? Where's the next step? So a few graphs. When I first looked at this, I thought, this looks good, and then I looked more closely and I thought, actually no, it doesn't look quite so good, so it does need to be explained. In 2011 we were doing about 40 crowns and 700 fillings. This is just in baby teeth, okay? By 2014, we'd actually sort of reached back to about 750 fillings overall. But in this interim, we were going up with our crowns, but we were still doing a lot of fillings. And I'm sure this is where we were in the process of having to cope with the ones that were failing while introducing the crowns. We then sort of had another slight blip, which was very interesting. In 2015, we were down to the sort of the same levels. 2016, when we went up again with fillings and with crowns. This, again, this is a slight sidetrack, was when we changed our service criteria for referral into the service. And we were starting to get children with much less decay, much earlier decay. So we were seeing younger children and treating decay earlier. So yeah, that would explain sort of the fillings staying quite high up there, because we only crown teeth if they really need it. We still use conventional fillings when that's appropriate. They were coming down a little bit, so by the end of 2007 we were looking at sort of 900 fillings, 800. As of this morning, we've done 375 fillings in primary teeth this year and crowns. So we are, I hope, this year going to start seeing more of a downward turn. So, are crowns reducing the number of fillings we're doing? I think they now are. Looking at the global evidence, what other evidence have we got locally? Well, we did a survey in 2011 and 2016, and in 2011, 1 in tooth in every 3 that needed filling in reception year children had been successfully filled. In 2016, 2 in 3. So these are teeth that had decay. We only had a third that was successfully treated. Now we're up to 2/3. So I think that's pretty positive. And then we also do the screening program. In all reception year children get offered this. They don't all take it up, and these are the figures just for the obvious decay. So the children that we're seeing with obvious decay, 2012 we're up to 130. This year we're down to about 38, 39. Okay, now that's not saying they haven't had decay, but this is they have obvious active decay at the time of the screening. So I think we're going in the right direction, and I think the crowns are definitely behind there. Also, emergencies for toothache. We've only been collecting this since 2014. We had 161 in 2014, 76 last year. So that is a huge reduction just for toothache. Okay, we record it for other things as well. And I did check, and I know we're on a further downward spiral this year, which is, again, good positive news. So, in conclusion, we're still seeing this, unfortunately. We're still seeing very large fillings that break. What we're looking for with parental consent and encouragement is fillings like crowns like this. There go 2 lower teeth and a top tooth. Where do we go from here? We're looking for smiley faces, okay, with nothing. But in the meantime, these, I think, are definitely working, and there's quite a lot of evidence out there. Thank you very much for your time. If you've got any questions. It is a bit of a minefield, and I think from our point of view, I think we wanted to sort of, I'm going to sort of do the background and give you a flavour of some of the complex issues we have to deal with within the health visiting and the school nursing service, because I do have to say that we are, being a universal service, we do see every child on the island, so from birth right up until they're 18. So the job we've got to do is absolutely massive, and it seems to be increasing as time goes on. And having that massive workload really brings the risk in with it, and I suppose Debbie's going to talk about how we sort of manage that risk and how we plan for that risk. It isn't as easy as it sounds. So my background is in practice nursing and health visiting, and historically practice nurses and health visitors have been the cornerstone of immunisations for many years, and I remember a time when the vaccination schedule was so small, and it's changed dramatically. So can anybody have a guess? And the guess is on the poster. How many vaccinations do we give in Guernsey in a year? Pardon?
I don't want to say because I know it.
Did you have a look at what was going on? Sorry, what do I do here?
If you turn the clicker the other way.
Oh, it's that one, sorry. So it's 6,500 vaccinations. So if you can imagine that we're seeing those families, we're seeing the parents, we're at every contact counts, we're actually seeing those children and families. It's a big workload, and you wonder why the school nurses are run ragged in September when we kick off with the flu vaccination season. So after clean water, it's really powerful stuff. That vaccination is the most effective public health intervention in the world for saving lives. So for public health and apart from water, vaccination is absolutely key to obviously herd immunity and to protecting children against these very serious illnesses. And I always say, well, actually, we don't see these illnesses because vaccination is so safe and effective these days. And I think parents forget about the seriousness of what actually can happen, and it's the vaccinations that really protect the children. So I just wanted to show you a little bit about historically the vaccine development over the years. So you have to go right back to the 1700s when Louis Pasteur, the first one was the bacterial smallpox, and we do. It's really interesting to see about how it was in 1967 to 1969 that smallpox was eradicated, and I know we're moving forward to eradicate polio as well. You can see that it's been massive. There's been massive steps, and in Guernsey, we started, the school nurses and health visitors started vaccinating in 2007. But you can see the changes. And again, that is just, it's a rolling programme, and every time there is a change in the vaccination schedule, every time we have to react to what's moving forward in the future. And as I said before, it seems to be more and more asked of us, and in fact the latest is the HPV is going to be offered to boys in future. I don't know whether you've heard that, but again that's going to have a massive implication on our workload. So immunisation is successful and cost effective health protection intervention, and as a cornerstone of public health. So as I said, high immunisation rates are key to the spread of infectious diseases and possibly death. Really powerful stuff. I do remember very early on in my nursing career,
nursing a little boy who died of measles and encephalitis, and he was an unimmunised child from Pakistan. And that stays with you because it's something that you don't forget, but again, I think it highlights the importance of herd immunity. So, to promote the core work of health visitors and school nurses, our Healthy Child programme is what we work to and deliver the core contacts for health visiting. So we will, in Guernsey, we're working towards this core programme depending on the level of need. So we will visit children, as I said, 10 days, between 10 and 14 days, and then at 6 weeks, 9 to 12 months, and then again at 2 years, and that's our core Healthy Child programme. According to the level of need, obviously that depends on their circumstances, and at every intervention, like I said, we will have every intervention. We will try and promote health at all those contacts. And that's the latest document is The Best Start in Life and Beyond, Improving Public Health Outcomes for Children and Young People and Families, Guidance to Support Commissioning of the Healthy Child, and that's 0 to 19 now. So how do we know what to give? This is just a little bit about what I was saying, so you can imagine that in Guernsey, this is the obviously UK schedule from spring 2018. It's changed dramatically over the years, and in some cases children in a GP surgery will receive 3 vaccinations at once, which is really very cruel, and if you ever heard so it is very, very difficult, and some of the challenges we have to do is actually unpick. So if they've moved into Guernsey, we will have to unpick where they are in the schedule and what vaccinations they need. So the GPs in Guernsey will give all the primary vaccinations. So that's at 8, 12 and 16 weeks old. And again, they will do the one at 1 year. And then moving forward, you can see the next lot of schedules, which is, you can imagine, it moves forward as they go through the school years. And again, it actually tells you the bit for the elderly as well. So you can see from that, there's a massive workload for us to achieve. So the history of the school nurses and health visitors started, I think I mentioned, giving vaccinations in 2007. And the health visitors give the preschool boosters, diphtheria, tetanus, pertussis and polio. And the school nurses give 1 booster, diphtheria, tetanus and polio. And at the time, as I said before, this was a huge ask and a massive workload. And the school nurses and health visitors currently offer protection to children from over 10 to 14 diseases. So you can imagine, one of the challenges, just as an anecdote, we face is that we had, I don't remember the thunderstorm, but we had a lightning strike at Lucas House, and the vaccine fridge was obviously the cold chain was affected. So these are the other challenges we have to manage about the practicalities of managing all these vaccinations, the storage, and making sure the quality and effectiveness of the vaccines there. But that's just a small example of what we had to face this week. I'm sorry, I missed off the others there. And we also do offer BCG, which has been in very short supply. So what do the health visitors provide? So 650 children will be seen a year when they're 3.5 years old. And that's been going on this morning, so it's a very busy clinic, and we often get asked a lot of other things as well during that contact, and there'll be approximately 35.5 half-day clinics offered. And the school nurses provide the nasal flu spray, and it's really interesting to go back to the floor because I do participate in delivering those sessions, Nasal flu spray is much better tolerated and accepted by the children and the parents alike, but I do have to say there is some scepticism over even flu these days, and we do get immunisations that declined. One of the most powerful things to share with you about the responsibilities of healthcare workers being passionate about immunisation and having a good understanding of the effectiveness, because that goes a long way for uptake rates. But we still do have obviously parents who decline vaccination, and it's interesting to talk about why they have those opinions really. It didn't help with remember Andrew Wakefield. He did there was a published in the Lancet a study linking autism and inflammatory bowel disease with MMR vaccine, and that caused massive scepticism way back in the day. I remember that I think in London uptake rates went down by 30%, and we had outbreaks of measles then. So really, it is really sorry.
He's carrying on his mission in America now.
Yes, he has, hasn't he? He got struck off, and he's working independently there. So, yeah. In autumn 2017, we provided this to 64.8% of children in reception in years 1 and 4, and that was 2,121 doses, and we therefore expect to give up 3,000 doses in autumn. And I can't remember where I said. Where do I? I can't remember where I said we'd swap over. But so the school nurses do the HPV, and as I said earlier, that's going to be rolled out with the boys, and they require 2 vaccinations in year 8 and 9, and obviously that is 90% re-immunised, 298 year 8 girls, which is 90%, and 289 year 9 girls, which is 94%, which is really good. I think we were discussing earlier in a meeting that we had with Alex, weren't we, about uptake rates. So we are aiming for 90, 95% and 97%.
There's no recommendation on HPV at the minute, but World Health Authority recommend measles containing vaccine around 95% coverage, and the initial vaccines, diphtheria, Hib, whooping cough, there's a 97% coverage, and we're pretty confident our data is, we're doing some little tweaks with our data collection, but we're pretty confident our coverage is above that, and has been above that for
we've had 99%.
Yeah.
Really well with them.
Yeah, so and school nurses obviously will do the school leavers, boosters, diphtheria, tetanus and meningitis ACWY, and they've offered to all students in year 9, and it consists of 2 injections for each student, and you ought to see the dramas when we have lots of fainting and lots of dramas going on. You can imagine, I think it's that they get sort of hysterical sometimes, don't they? So you put mats out to catch the fainters, but but it is quite a big ask, and again it's a massive workload. Unusually 3% of them declined the immunisations, which is ironic really, because as soon as there's an outbreak you will get inundated with requests to vaccinate again, so it's really interesting. So the remaining 5.4%, approximately 32 students, we'll continue to work on, and we do keep trying to catch them. And in total in the school year 2017-18, 32 trips were made to school, so again it's a lot of work going on, and I suppose it's about managing those risks to make sure we get the right vaccines to the right children. And Debbie's going to talk about how we manage that and how we try to mitigate the risk, because we do want to learn from our incidences, and Debbie's going to tell you how we do that.
Right, okay, obviously we're giving a huge amount of vaccinations,
And how do we give them safely? Because we have made errors with these in the past. So we're going to have a look at, how we plan it, the safety, the technology that, and the staff and the service users, because there's always issues. There's always sort of risks there with all those 4 aspects. Okay. Oh.
It's the right hand one.
Right. Okay. School programme is organised in early in the year, and all the dates will be booked. There is quite a challenge sometimes with schools. We can't do that because we're busy. But we have to do a bit of careful negotiation with schools. Pharmacy will then be advised of the dates of our programmes and the approximate number of children we expect to see at each session. Julie has mentioned, we started giving the flu vaccines a few years ago, and that has gone up and up and up, and we're doing all primary children. So we will be, our child health administrators at the moment are stapling together 5,000 letters to send out to parents, so quite a job for them as well. And also we'll let them know what they're having, because they have got to give they've got to send us the right vaccines at the right time. We did have quite a big drug error. I could tell you the exact date of it because it sticks in my mind firmly forever and ever, where pharmacy instead of giving the school leavers booster, sent the preschool booster, which has their whooping cough in it, and we'd given 50 vaccines before one of the school nurses went, this might be the wrong one. Very similar names, very similar packaging. So we immediately stopped that session, obviously. I then had to write to all the parents and say, I'm really sorry that this has happened, and this is, this is what's, this is the reason for it, these are going to be the effects on the children, etc., etc. And I also got hold of the manufacturers of the vaccine to say, this is a potential mistake here, because, there's a potential difficulty here because it's so similar, the packaging is so similar, and the names are so similar. Actually, they haven't changed the packaging and they haven't changed the name of it, so it didn't do any good. But those are the sort of things that we will do after such an incident. We do have different systems in place to check, but that was despite the nurses checking each other's vaccines, that they still got it wrong. We send the letters out to the parents with vaccinations and consent forms. All the consent forms require check-in prior to the session, so we're dealing with thousands of those. And the preschool health visitor clinics are organised and scheduled by admin staff at Lucas House, and appointments are sent out to the parents there. A lot of this is about engaging parents, and health visitors will do that right from first visit. We will talk about immunisations. We talk about immunisations just about at every visit. We will chase people up, and the school nurses will go into schools, to parents' evenings, and talk about immunisations and how important they are, and they will go in school newsletters as well. We have good liaison with the schools, which has been worked on to get good access, and schools are really good at helping to get the consent forms in. And some of the children will opt out, but we do some of the older children, but we will do catch-ups and so try and get them. And for the vulnerable children and the looked after children, we have liaison with a looked after nurse, and where do we need to deliver those services? Do we need to deliver them in community settings? And there has been times when the health visitors have gone out and given immunisations in the home to children where parents haven't brought them along to the clinic. So the training, we work on the national minimum standards and core curriculum for immunisation training, which we do annual updates. We have a mixture of training. We will get people who come down to do training for us. We'll do online training. We also have our immunisation nurse who will do updates for us as well. And then there's a competence assessment tool as well. What we're having a look at the moment is a really good, quite comprehensive online tool for an online training, which is probably better than people sitting and listening, because actually you can sit and listen and you can switch off. But if you're doing that online and you have to pass an assessment, then it makes people do that, and we can just check up that everybody has done that training as well. Okay. We have minimum. We have a minimum sort of standardised framework and of what we do, and that is written down in a standard operating procedure. So those checks and balances are done to prevent an incident like lots of children being given the wrong vaccination. Also of importance is the cold chain and storage. That is difficult when we are taking things out into schools. That has to be monitored very carefully, and then monitored by pharmacy when we go back, because if the vaccines have been out of the fridge for so long, then they have a shorter shelf life. So we work very closely with pharmacy with that. And then we have the audit points as well. And Child Health Administration will put all our immunisations onto the system that are then sent to the GPs, and that is a child's record forever and an adult's record forever. So it's really important that we get it right. So reporting mistakes, well, the first one is putting a hand up, and although as a manager it makes your heart sink when somebody says this is what we've done, but it's creating a climate where you go, it's not a problem, well actually it is a problem, but let's deal with it. And as far as we know, people are really good at doing that. They will come back and say, I've made a mistake here, and it's dealing with it appropriately. Safer Everyday initiative, bringing this into immunisation work, and learning, using errors as a learning opportunity, which we have done, and we've put procedures in place, we've put training in place, and the timely reporting of errors as well is extremely important. And also because we've got, you've got parents and children involved, it's really important that we do let parents know, absolutely truthfully what's happened. Technology, we're developing a gov.gg website, so we've got our own online resource. We're looking at consent forms, online consent forms, and also we have our electronic health and social care, which is records, which is real. We've got a lead nurse for the school nursing and health visiting, which we've had for quite a long time. So you've got one person who is overseeing all those immunisations. That person is a member of our local immunisation committee, and Julia was talking about the immunisations for the boys, the HPV for boys. Well, that has got to be recommended by our local committee. Usually we go along with the UK guidelines, but that's decided locally. We have that specialist post, we have a specialist nurse who is dealing with that, who will look at all our procedures, our patient group direction, because that's how we administer them. Okay, so thank you.